Hello and welcome to the Surgical Spirit podcast. I'm your host, Dr. Haidar Al-hakim, the Third Eye Doctor. Pull up a chair and get ready for some candid and uncompromising discussion with experts, innovators, agitators, and influential people from every corner of health and well-being. From inside the hospital to at home in the kitchen, we're leaving no stone unturned in our quest to uncover the secrets of healthier, happier, more successful, and less stressful lives. Thank you so much for joining us, and without further ado, let's meet this episode's guest. Hi Rachel, thank you for coming on the podcast today.
Hi.
I heard you on a conference which I thought was a really unique conference, the Wounded Healer conference organised by Practitioner Health. And I mean, for individuals that don't know who Practitioner Health are, it's an organisation that I think every healthcare professional should at least research or maybe even get involved with, because I think being a doctor should have a bad for health sort of sticker label sort of on there from just from the inception of thinking of becoming a doctor. It's like, well actually being a doctor does come with a lot of health warning sticker labels that you should think about. How do they approach you? What's the story behind Practitioner Health getting involved in?
Well, I've been involved with Practitioner Health a bit for a while. I mean, I've been working on suicide since my own experiences of patient suicide very early on in my career as a consultant psychiatrist, and met Claire Gerarda, who also does quite a lot of work with suicide, and she works with the suicide of doctors and sort of aftermath of that, whereas I work with trying to understand the nature of the suicidal act itself, because I'm a psychoanalyst, so trying to understand the psychodynamics of suicide, and try and really understand the mechanisms that lead someone to do that, and also the profound effect a death by suicide can have on those who are bereaved, which for a large part of the work I do is the clinicians who've been working with the person that dies. So they're very, from my own experience of being profoundly traumatized by a series of deaths by suicide, and nothing being available or supportive at that time, and no discussion whatsoever about the impact that this actually has on you, to working over the last 15 years on trying to understand that impact, but also trying to develop resources and support for clinicians. And in that work, then I lined up with Claire, and actually have done some work with Practitioner Health around that as well, done some work with them, because they see doctors who've also been traumatized in this way. So we were linking and discussing that. And I've done presentations for them before, and I think they thought, well, this is quite helpful. So let's sort of have this on a wider, put this discussion around suicide on a wider, sort of in a wider forum for a wider, sort of to open it up for a wider discussion.
Mm-hmm. And what did you think of the conference itself, the Wounded Healer conference?
Well, I thought it was a very good conference. But I think a lot of the work that Practitioner Health and Claire have been doing, I think, is raising awareness of the patient inside us all. That as doctors, you're talking about doctors, that come in with a health warning. But I also wonder whether there's also something to become a doctor. I think there are probably particular vulnerabilities that we have in our mental health already that actually make us particularly desire to be a doctor, but also have the characteristics that are needed to be a doctor currently. Maybe that'll change with time. So I think we come in with our own particular vulnerabilities, and then we need to do this for a reason. So I'm not quite sure. I totally think that the job makes us ill, if you like. I think we need to sometimes go through these experiences, but I think not having the support around these experiences and not having compassion and understanding for ourselves and for our colleagues can damage us. So I think in a way it's, yes, the experiences are very hard, but I think there's something in the way that we respond to ourselves and each other, which really contributes to the mental health difficulties that we have.
Yeah. I mean, that was one of the questions I asked a previous guest, that, do we have to go through the trauma or the difficulties ourselves in order to understand what it means to treat patients. I mean, she was treating patients with PTSD. Can really treat them unless we actually go through it ourselves.
I think it might be the other way around. I think we might have already been through it.
Right.
Actually, and I think we maybe need to go through it with our patients to help understand our own much earlier traumas, actually.
So it's understanding what we've been going through all along, and conveying that in a therapeutic manner towards our patients.
One of the theories, a sort of psychoanalytic understanding about doctors and working in mental health, is we project a part of ourselves, the patient part of ourselves, into our patients, and then we can look after our patient. And by doing that, we look after the patient's part of ourselves, but we can't look after the patient in us. We have a profound difficulty in trying to acknowledge and accept the patient within us. And the really interesting thing about the pandemic, and I think practitioner health, is about, the pandemic brought the patient in the doctor out on the surface. So we became very clearly patients in the process of the pandemic. We couldn't disown the patient part of ourselves anymore. So the pandemic brought that to the surface. And it's very interesting. I'm a member of the wellbeing committee at the Royal College of Psychiatrists, and there was a presentation there of one of my colleagues who set up a wellbeing service for psychiatrists, actually, during the pandemic. And he found that all the psychiatrists, there were many, many more mental health practitioners generally, many more that referred than he thought was going to happen. And actually, they all had secondary level care mental health problems. So we have secondary care level mental health problems, and we're treating people with secondary level care mental health problems. Interesting. And that's also what makes us very, very poor patients, because when we have to be a patient, we have to accept back the projections that we give our patients. It's not necessarily an easy thing to do.
I mean, can this happen over a period of time, or is it sort of can it happen quickly?
The becoming a patient, the
taking back of the.
I think it probably takes time. I think it probably takes time. I mean, this is why when you're trained in psychotherapy, you have to become a patient. You have to become a psychotherapy patient, and that's over usually many years to learn to take back. To learn to take back the patient part of yourself. Yeah. And I think in doing that, I think when we can acknowledge our own vulnerability and our own mental health difficulties, which I think is becoming much, in the environments that I talk in, doctors are starting to talk about their own mental health difficulties much more than they did. And I think in being able to accept that, I think it makes us better clinicians.
And do you think that shift has happened? I mean, there's the pandemic. Did it happen before then, would you say? Was there a shift?
I think if you can see the trajectory of practitioner health, I think it probably follows a bit to do with the growth of practitioner health, this recognition that actually there really does need to be some mental health support for doctors. And then it has grown and grown and grown and grown, with awareness growing as well, and demand growing and need growing.
Do you think there's a society role in this, or is it just professionally led by the profession?
It depends what you mean, the societal role. I think, yes, I think there is a change in perception of doctors from being invulnerable heroes, from being the sort of heroic, invulnerable sort of profession, to recognizing vulnerability. But I think that's probably come in part to do with the need. I mean, personally, I think a large aspect of this is to do with what's been happening in the National Health Service and the increased pressure that's being put on clinicians in general in the National Health Service. And to stay there, I think, necessitates, the development, I think, of some significant psychological. It's a significant psychological challenge to remain in the NHS in many situations at the moment. So I think it's putting doctors under immense pressure. And other clinicians under immense pressure. So that's the sort of pressures on the NHS, I think, are being reflected in doctors' mental health and other clinicians' mental health.
which is a major problem because the pressures are mounting and the staff
Mm,
numbers are dwindling, and
yeah, huge
so
issue.
we've reached a tipping point. Well, I mean, we probably reached tipping point many years ago.
Yeah,
um
I think so. I did a talk in 2018 when I left the National Health Service in 2018, and I did a talk which is online actually, which is called "The Impossibility of Working in the Current NHS." And at that time, definitely, it felt to me, certainly my understanding is that this wasn't sustainable. It just isn't sustainable. You can't carry on having an increase in demand with the reduction in staffing. You just can't. And at that point, it had gone beyond the tipping point. And what you could see then was that what the government would say is we put in all these billions into the National Health Service, but what you could see about the use of that money was it was on locum staff, and actually the employed staff were going down and down and down all the time. So at that point, it really did, and the referrals. I mean, the referrals to secondary care mental health services have hugely increased. So you've got a totally unsustainable situation.
do you see any light at the end of the tunnel for the NHS in this current situation? And if not, sort of, what are these solutions?
Well, that's a huge question, and I think, and I'm not sure that I can't answer that. I mean, I think there's something about the need to think at a deeper level about actually what's going on, and I think this probably speaks to a lot of the work that I do. I suppose my belief is you have to look after the staff. You have to look after the staff, and care about the well-being of the staff that you've got. And all the clinicians that are working in the service. But the trouble is, and I think that really has to be thought about at a deeper level, because people can leave. They have choices. They can leave. So I was looking in the paper yesterday morning, and there was the government minister, I've forgotten because everybody's changed so much recently, was saying doctors have to work at the weekend. We have to clear the backlog. We have to have doctors working over the weekend. Now, I've been there before when that's happened. Well, that's great, but how is that going to be resourced? And how are the doctors, whoever it is that's doing that, is their well-being not going to be negatively affected? Because again, if you put an awful lot more pressure on people to work longer hours, to work weekends, they're going to leave. It's as though there is some fantasy that the staff that work in the NHS do not have choices, but they do. They don't have to stay in a relationship with a workplace which makes them unhappy. So that I think a really, really key issue is thinking about workforce well-being.
And we're talking about the deeper questions here, not the sort of put this plaster on and do these exercises.
No, and I suppose the other thing that I brought up in the talk that I did about the impossibility of working in the current NHS is that I think there's something unrealistic underpinning our beliefs about the NHS, which is the basic tenets of the NHS as they were described initially have nothing about resources in it. And basically what we're believing and what we're trying to do, our primitive unconscious is sort of manifest, which is we can give everything to everybody whenever they want it all the time. And we cannot. And we have to come to terms with something, I think. And I think in there, the wider public has a role to play, because I think there's something about sort of facing reality, and that we can't give everybody everything whenever they want it all the time. We have to think about resources. We have to. And that sort of, in a way, it needs to be, I think, written in to the sort of underpinning ideas in the NHS. And I think there was a fatal flaw written in when in the development of the NHS, that there was nothing about resources in there, and it was playing to primitive fantasies, which of course have extremely, there are really, really important and healthy ideas underpinning it about being able to provide good universal healthcare. But there has to be thinking about resources. And I think this fantasy that we can give everybody anything they want all the time, whenever they want it, needs to be thought about.
Yeah, I mean, it sounds like a defunct mythology that's persisted, and we're being told to follow that defuncted mythology.
But we
You
have a
know,
role to play. We have a role to play in signing up to it. We're not being asked to follow that. I think there's a part of us desperately trying to hang on to that.
yeah,
I want to, I want to believe that I can have anything I want healthcare wise whenever I want it all the time. I do want to believe that, but that isn't reality.
yeah, yeah. I mean, you know, there's a profound pattern there for sure, but it doesn't mean that that pattern is realistic and reliable and is relevant in 2022. I think
No.
that's something that we're kind of grappling with. It's there on the unconscious, collectively, and it needs to be brought to the surface and have, you know, make it more consciously aware, I guess.
Yeah, I mean, our collective unconscious, our primitive collective unconscious does determine an awful lot of things that happen. That another whole area around this is the idea of blame. Someone's got to be to blame for everything. Again, is something of our primitive unconscious. Is there can be no losses, there can be no accidents, there can be no human errors. Everything has to be perfect, and if anything isn't perfect and there is a loss, a human loss, then someone somewhere has to be to blame. And blame is a very primitive word coming out of a sort of primitive state of mind, a sort of non-mentalizing state of mind, which I mean has actually little reality-based meaning. Blame as a word has very little reality-based meaning, but we all sort of seem to sign up to that. I mean, that's the parlance, if that's right, in our media, in our health services. It's the sort of parlance of blame.
Is that because it's a more archaic sort of survival mechanism that we have inside of us?
What it is yes. I mean, it's the primitive response. So that if I suffer a loss and I don't know what's happened here, so let's just take suicide for example as an example of that. So suicide is a very, very distressing, sudden loss, profound, tragic loss, sudden. And we do not know why it's happened. We don't know. And you can never find out why someone has died by suicide because they're not there to tell you. So you're left in this state of uncertainty. And we can't, and this sort of uncertainty really challenges our mind. We can't compute it. So what we tend to do, particularly in the acute early stages of a loss event, is we create a narrative. So there's nothing worse than uncertainty. It fragments our reality. So what we do is we very, very quickly create a narrative. And that narrative will tell us why this has happened. But actually, the narrative is delusional. It's not based in reality whatsoever. But it relieves us of the uncertainty. Phew, I know what happened here. This happened because somebody did this, and now I don't have to worry anymore or have to cope with the uncertainty of it. But it's totally unsatisfactory, and it doesn't work in the long term because it is actually delusional. But it happens for all of us. We write narratives about things that we don't understand or we can't compute, and we sort of run by these narratives. And blame is a word that is indicative of this delusional narrative. It's indicative. So if you work in personality disorder services, you talk about mentalizing and non-mentalizing states of mind. And we all, when we're very stressed, we get into a non-mentalizing state of mind where everything has to be this or that. And one of the words that is a sign that someone is in a non-mentalizing state of mind, a highly anxious state of mind where they can't think, is use of the word blame. So it's a sign that people aren't able to think if that word is used.
Yeah.
And we use it, and it's not unchallenged, and it's in our newspapers, and it's in, it's used in, by leaders of the country as though it's not delusional, but it is, as though it's not, it has meaning that it hasn't got.
I'm just interested why it has so much power and so much influence on oneself and also collectively as a group in society.
Because I think it helps us in mourning. It helps us, in a period of mourning. If we have someone to blame, if we can scapegoat somebody, all the sort of murderous feelings that come up to do with loss, one of the stages of grief. So when we suffered a loss, we have different stages of grief. And an early stage of grief is you have a period of denial, and then you go into a stage of anger and blame and murderousness, actually, really. I mean, I'll quote a friend of mine who lost her daughter, who said to me, you know, if you'd have stood in front of me after I'd lost my daughter, I could have shot you and I wouldn't have thought twice about it. You know, there's something about grief that is very dangerous. There's a stage of grief that's very dangerous, you know, that is sort of murderous. It's a way of projecting out the anger and the fury about what's happened and the loss. But if we can get through, it's a normal stage of grief. If we can get through, we go on to bargaining and then to sadness and acceptance. So it's a normal stage of grief, but it is quite dangerous. And the thing with blame is it fits in very well to that stage of grief and mourning. And if we can powerfully shoot out our aggression and our murderousness, and actually psychically or really kill someone in a lot of cultures, a lot of different situations. I mean, actually all of us, you know, can contribute to actually people being persecuted or scapegoated and murdered, you know, after loss events. You know, it's amazing how often you'll see this with people, individuals being exposed after loss events and held responsible. And it is, we've got a sort of string them up mentality. But if we understand that is a part of the mourning process and can be contained culturally, then that's okay. But if we don't understand that and we actually think that this is okay and we sign up to it and we sort of collude with it, then it's not okay. But that is, you know, there's a real struggle with that.
Yeah. So, you know, one can argue there's an onus on us as a medical profession to sort of call this out and bring it to the surface and you know, discuss these difficult stages of mourning of trauma within the profession.
Yeah, but you know, I certainly, when I trained, we had half a day on the mourning process in training. And you know, the other thing that also makes it very difficult is, as doctors, we're extremely stressed. So we're not in a mentalizing state of mind a lot of the time. And we often very frightened. So if we just talk about the case of Hadiza Bawagawa, for example, where you actually have a doctor who is charged with manslaughter and convicted of manslaughter after a death, after, you know, as a result, in my view, as a result of something becoming very uncontained in the mourning process. So you actually have a real attempt at annihilation of somebody. So we have reason to be frightened in the culture that we're in at the moment, that, you know, we're dealing with loss and grief and people die, and we might be caught up in this and blamed and persecuted ourselves. And a lot of us have been at different times. And that makes us very frightened. And what tends to happen when you're very frightened and you're in that state of mind is you just think, please let it be you that gets this, not me. And you're just so relieved that actually it's your colleague who's getting blamed for something, not you, because it's a fight, flight, your survival state of mind. So I don't think, you know, it's very difficult for us to have the capacity to stand back and try and work together and support each other in trying to counter this culturally. You know, but ultimately, you know, we really, as a profession, do need to stand up for each other and ourselves and stand together. You never get scapegoated if someone is sitting with you. So, you know, there is something about us working together as a profession and trying to stand together to not join in with this the sort of persecutory environment we might be working in and functioning in, and to support each other. And
you know, this service, practitioner health, is addressing that to a certain extent.
Yeah, no, very much so.
Yeah. How did you get interested in psychiatry?
So
that long game.
a bit of a change of direction. So my grandfather, well, he was a GP. He was German Jewish, came over 1933. And he was a GP, but became a psychiatrist and was very interested in psychoanalysis as well, and sort of set up the Brandon Centre in London for young people, but very much along psychoanalytic lines. So he was very interested in psychiatry. And I remember in his living room, he was very depressed, post-Holocaust, very depressed. But what he had in his room was all Freud's first edition, you know, standard edition of Freud. And I remember being totally sort of, it was a bit like having the Bibles, you know, he had this sort of thing. And I remember being very drawn to them and thinking that there's something in there that could help with all of this, you know, the post-Holocaust pain or whatever. There was something in it. And then I worked in the BBC for a while after leaving school and went back to do medicine as a mature student. Both my parents are doctors, and I tried very hard to avoid doing medicine, but felt
Why?
Because I saw how difficult it was. You know, they were both working all the time, and they were struggling and very stressed and anxious about their patients, but clearly having a very meaningful job, clearly very meaningful. So I tried to avoid it for a while, and then thought I can't. And sort of similar things happened to my son, actually. But and then, you know, if something's your vocation, you can't avoid it. And it was like going into the church in my family in a way when I said I wanted to do medicine. And then I was doing medicine and thinking, yeah, I could do GP, could do obstetrics, I suppose. And on my first day in psychiatry, I remember sitting down and they said, oh, Mary Robertson, who I worked with, she has a long ward round, you know, 6 or 8 hours. And I thought, good heavens, that's terrifically long. And I put on comfortable shoes, thinking that we were going to be walking around. And I was led into a room to say, oh, sit down. Would you like tea, biscuits? And then we talked about the patients with like real interest about their histories. We met them, we met their families. We then discussed them again. And I thought after the first day, this is the best job ever in the whole world. I can't believe there's a job as wonderful as this. And I don't think I ever stopped feeling that. I don't think I have stopped feeling that.
And the BBC, what did you do in the BBC?
I was an engineer.
Oh, wow.
So I went in at 18 or 19, and I was a female engineer. And I was one of the first female engineers they had there. So for a while, I do not know how I got in, because I absolutely no capacity for engineering whatsoever, really. But I'll blow up the
capacity
equipment.
being the word, you know, capacitors and everything.
Yeah.
So what exactly did a BBC engineer do in those days?
So I worked in outside broadcast. So what we used to do is go to any live event and set up sort of temporary studios and radio links, so it could be broadcast live. But at that time, it was in the 1980s. You know, there was a lot of drinking in the BBC at that point. Certainly in the environments I was in, it was, you know, I was the only woman. I was the first woman in outside broadcast at that time. And I got in my interview, I got asked all these questions. And one of the questions was, if you set everything up and it was lunchtime, what would you do? And I thought this was a trick question. And I was, well, I'd check all the equipment and I'd make sure it was all, you know, fine. And they said, no, what would you do if there was the option of going to the pub? Would you say yes to that? And I went, yes. And they went, great, tick, you're in. That's obviously the main thing, particularly as being, you know, they obviously needed to get some women in, because they'd obviously been told this was the case, and they were very frightened that somehow a woman would come in and really spoil the way that they functioned. But actually it was very good fun. It was a very enjoyable job, but not one that I would have wanted to be in all my life.
So what was it about that job that you thought, no, not for me anymore? And
well,
you know,
the amount of drinking wouldn't have been sustainable, and it was very, very sociable, but for me and it lacked meaning. For me, it lacked meaning. And I think that was the, you know, it was extremely, I really enjoyed it. And again, lovely people I worked with, but it lacked meaning.
And did your grandfather meet Freud? And did he sort of?
Yeah, I think so. Yeah, well, he had an analysis from an analyst called Frieda von Reichmann, who was an analyst in Germany, one of Freud's contemporaries. And his wife, you know, knew Anna Freud very well. So worked at the Anna Freud Center. She was a child and adolescent analyst. So yes, they were very much part of that that culture.
Yeah, sort of growing movement and probably cult at that time, and you know, things were bubbling up unconsciously.
Yeah, I mean, it's a very, very creative time, but also the time of refugees and coming over from Germany, you know, the sort of exodus of Jewish academics from Germany. So complex, very sort of complex, very creative, but also very traumatized.
And did you hear sort of a lot of stories about the Holocaust, or was it not really talked about amongst your family?
Oh, no, I don't know. certainly I'm a third generation, so my father was born here, and I think in common with many third generation, my mother's Irish Catholic, but my father was Jewish. In common with many, I think, third generation, we were very, very exposed to the Holocaust, non-stop. We used to call it in my family with my dad. My dad couldn't stop talking about the Nazis and the war, and he'd be reading stuff about Hitler all the time. And so it was I was got to watch I can't remember what it was, the Holocaust series on TV when I was very young. You're very, very exposed to the Holocaust. There was no escape from that. And I think my children are much freer of it than I was.
But it only takes time, that they get fascinated again with age, and with coming into wisdom and into realization.
Reparation takes generations, I think. My daughter is now in a very, what looks to be a very healthy relationship with a young, lovely German young man. So reparation takes generations, I think. And it's quite hard work.
So how do your parents get together? One's Catholic, one's Jewish. What's the
doctors on the ward? Ward rounds.
So like medicine transcends religion and sort of all that stuff.
I think that's interesting. That's an interesting point. I think it can do. I think that maybe is the yes, that's the belief system that does. I mean, it does. Yeah.
Which is a bit dangerous if we intertwine NHS, with this. So the NHS supersedes the the transcendent, and then we're back to sort of square one again.
Yeah, and I think it's interesting. I think there's quite a few. I know quite a few Jewish Catholic, Irish Catholic, couples from that generation. And I just wondered whether there was something about the guilt. There's Jewish guilt and Irish Catholic guilt that somehow, again, maybe that transcends as well.
Yeah. I mean, I don't know. I think the Jewish Catholic guilt is stronger than the Muslim Jewish or the Muslim Catholic. I mean, I'm sure there's listeners out there, and if they are listening, it'd be good to hear from them about how they've, transcended the sort of Muslim Jewish ideological clash, so to speak.
What's the Muslim guilt like?
Profound.
Yeah, a bit more along the lines of Jewish guilt then.
Yeah, very profound. I mean, from my family history, we lost a lot of family members because of faith, and that was only 40 years ago. So we're kind of newish in terms of dealing with the guilt. But yeah, it's very traumatic, and it's taken me some time to kind of process that and take back my projections, my horrible projections on my patients. But yeah, it's very evident, when I'm in positions of fear, how I'm projecting all my negative guilt, shame, and anxiety-driven negative characteristics that I project on my patients. So yeah, it's taken some time. I mean, psychotherapy and psychoanalysis has helped a lot, actually, in my journey of being here today and speaking to you today. So maybe it's something that should be part and parcel of, being a physician, that.
Well, I thought it was. I absolutely certainly thought it was part of being a psychiatrist. And I was talking to somebody else who was saying, it's actually a person, younger generation than me, who also said the same thing, is that they went into psychiatry and absolutely thought all psychiatrists would have their own therapy. And I remember being horrified to find out that wasn't the case. It seems... I
mean, it doesn't make sense, really. I mean, because you're looking through your own lenses. So everything's been tainted with your own just mental processes, let alone, your own unconscious, which is, I guess, infinitely complicated and quite confusing at times. I mean, I gave a talk about dealing with burnout, and I talked about the unconscious, and it was very confusing because, medicine comes with a different paradigm. It comes with certainty.
Mhm.
And, what we're talking about here is sort of uncertainty in dealing with plausibility,
Mhm.
which is a different side of the coin.
But I
But
mean, again, certainty is a non-mentalizing state of mind, and sometimes you need to be able to go in that to be able to make a leap.
yeah,
I suppose to be able to go and leap into having surgery, you're
yeah,
very anxious, and there has to be, it performs a very useful part of our functioning to be able to make a leap of faith, if you like, when we have to
yeah,
take a risk.
yeah. I mean, that's why the NHS has that sort of faith-based proposition. It's there, and that's what's keeping it going, because it's supernatural and it's beyond the certainty, but we still have that certainty that it's beneficial and that it's going to move us forward. Coming back to the notion of the trauma that my family went through because of their faith, it's been a total curse, but at the same time, it's a total blessing as well. Because of the pain and the suffering that one goes through, other people can understand that and reflect upon it and find insight into their own pain and suffering, which I think will bring them forward into new horizons of experiences.
But there is also something in that to do with intergenerational responsibility, isn't there? I mean, again, with it may be the same for you, but certainly being brought up with the Holocaust in your background, you become extremely aware of intergenerational trauma. And there's something being aware of that. I think there's something about, well, how do we mitigate that for the next generation?
Yeah.
How do we not perpetuate something, and how do we mitigate it? And I think for me, that's a very important aspect of being alive. One of the important tasks in my life is to try and process some of this trauma, so I don't just pass it on.
Yeah. And I think that's where sort of wisdom practices come in, and I think that's where you find the wisdom in these experiences. And the whole notion around finding wise practices in art, for example, and in beauty and in truth or in love, that allows us to mitigate the trauma so that we can dissipate the just the pain, but not dissipate the other insights that we can get from previous generations, in order that the same mistakes don't happen again. I mean, that's the underlying sort of ground in which we try and move forward with this, is that we don't make the same mistakes.
Love is an interesting one, isn't it, really? I mean, we can use that. I mean, it's interesting about the role of love and how difficult it can be to access that, how elusive it can be, but how how blocked it can be.
I mean, I think we've essentially, I mean, I use this term, I hope it's not too crass, but we've bastardized the term love a bit too much, and we've turned it into something else, which it isn't. And I think that's a reflection of how materialistic we've become. So we've turned it into a materialistic kind of having, and a consummation way of thinking, like an eros way of exhibiting love. But
as in an ownership type of way, you mean?
Yeah, just consummation. Erotic love is consuming something that you enjoy doing, whether it's having sex or eating chocolate or drinking coffee. So
but also I think what you're talking about there is a bit about the assuming some sort of ownership of a love object, that actually it's a sort of extension of ourselves.
Yeah
That it isn't really, it's what I would think about, I don't know, with you, a sort of primitive love. This idea is, this sort of codependent type of picture of love. I love you for what you're actually able to give me.
Yeah.
Rather than loving you and you can leave, I love you.
So I mean, if there's no reciprocal benefit to this, then definitely that would be sort of a an erotic love of sort, because I will combine with you knowing that I will get a lot of pleasure, probably more pleasure than you. Then that's the kind of, I think, love that is quite popularized now in modern day culture. The next level is the philia kind of love, which is the reciprocal combining and consummation. So we both benefit from this, by coming together and enjoy what we're enjoying. So that's like the next level. So that's what you call the pleasant life. Actually, not the pleasant life. There's something more than pleasant life. Sort of the happier life. Whereas the pleasant life is literally, consuming for your own pleasure. The sort of hedonic. And then sort of, the highest form of love, which is like the being form, which is the meaningful one, which is I raise you from, a non-person to a fully fledged person through my sacrifices. So that's the kind of agapic love.
So yes, well, I'm thinking a bit about that.
yeah. So
the way that you've described it, I'm trying to think about that. Because sacrifice is also an interesting concept, isn't it? What sacrifice is, because it can be very masochistic. I'm very anti-masochism.
Yeah, I mean, there's still a pleasant, there's still a, the reason why I'm masochistic here is because there's pleasure for me, and there's probably pleasure for me more than you when I'm doing this, this activity. So there's still some, erotic.
Well, that's, I suppose I'm the question about sacrifice, I think, is so it's another area that I'm very focused on, is to do with sort of sadomasochism, and right. I think as doctors we're very masochistic, but that is it's a sort of disturbing and needs to be challenged, really. Something in that functioning. So when I hear sacrifice, it makes me concerned a bit about that aspect of something.
Yeah, I mean, sacrifice in the sense that I'm giving myself to you in order for you to become someone greater. But in that process, it makes life more meaningful, and it gives me more insight into myself and what I can potentially be through that giving to the other person who I know won't be able to give back. So it's, it's a form of forgiving. So
is that a more spiritual thing? Because is it really towards another person, or is it towards a sort of like a picture of other, a sort of what would be thought about as something larger than ourselves?
I think that comes later. So, that's the after effects rather than the fore effect. So reflecting backwards, you realize that this gives you that sense of bigger than oneself, a transcendent function. But actually, as a way of trying to get that transcendent function, this is one of the processes that you are making. Essentially, the love of parents. The parents have this blob of meat. You don't have an erotic kind of love for them, or a philia kind of love for them. You have an agapic love for them, which is where you have this lump of potential, and you can quite easily leave them there and they die and disintegrate, or you can give yourself into that being, knowing that there's potential in order to create them into something even greater. And that process creates a transcendence within you, unrelated to a superior being so nothing to do with propositions here. There's no propositions, there's no procedures that that you have to follow to be accepted within a creed, but it seems to be some kind of way of making life more meaningful. I mean, I talk about these things because I think it's related to burnout. I think one of the major reasons why people burn out is because they lose the meaning of life. So there's a crisis of meaning. So how do we recreate a meaningful life, or how do we inject meaning back into one's life? So that's the kind of window I'm sort of looking through there. And, you know, because...
So with psychoanalysts, so as a psychoanalyst, I'd be thinking about that in terms of the commitment to the creative unconscious, that of a sort of, it's a larger task, a task larger than myself or even a couple.
Yeah, because, you know, you're tapping into the total unknown, and, you know, we can only work within the known, you know, the relevant known, but then, you know, that's sort of infinitely small. And then the more you tap into it, the sort of, you know, the more you realize that it's even more infinitely less known. So, you know, it is a scary proposition. But, you know, as you said, we've got to step into the into the abyss with faith, which is essentially trust. You know, you've got to trust that you will find the relevant information and use it in the most relevant way. But it's certainly a, you know, an interesting discussion. I mean, we didn't really talk about you know, the whole sort of truths that you found out about suicide. It'd be good to kind of hear a bit of that, because we're coming towards the end of the podcast.
Well, I was thinking about, where do I start with that? So what you were hearing me talking about was a sort of summary of years of, around sort of 15 years now, of engagement and thinking about suicide, and what seems to emerge from looking and thinking about suicide, and looking at data and talking to people. Are there some and you know, I'm part of a group that's been running for the last 15 years for consultant psychiatrists who've lost patients to suicide and now homicide, and you see certain patterns emerging in the things that people are talking about around suicide and their own responses to it. But what you start to see is certain patterns, and the patterns are repeated and repeated, and these patterns are different to what we're told about suicide. And I think really bear some engagement with and talking about it. When I do talk about it, you can feel that for many people it is a relief. I mean, there's something about suicide that strikes at the very heart of what it means to be human. And when you come in contact with suicide, it really shatters illusions that we might have about reality, because there's something, it puts us up really up against how hard it is to live. You know, I think one of the illusions that we have is that life is sort of easy, straightforward, not painful, but actually life can be, you know, when we tune into it, it's really hard. And I think there's something about suicide that really challenges us to face that ourselves. And, you know, again, psychoanalysts would talk a bit about the death drive, you know, that there is something about us being human beings that are driven towards, there's a part of us that's driven towards wanting, or whether wanting isn't quite the right word, but a real drive towards something, a sort of deathly state or death. And maybe the suicide that brings us up against whatever it is that's trying to be described by psychoanalysts in that way. So I think there's a lot to be thought about it. And I think the thing that what I talk about is, it's very difficult for us to comprehend or think about suicide. So what we try and do is we try and simplify it to make it into something like an accident, for example. So if someone's died, it's because they were looking at something on social media and that's then triggered this. Or that there was a ligature point left out, and they've, you know, like in mental health, there's a removal of ligature points, which are almost everything. And that someone has just sort of tripped over this. But actually suicide isn't an accident, you know, that suicide results from the psychoanalytic thinking, from complex and probably universal mental mechanisms, that we all probably have these sort of internal psychodynamics that could lead us to do this, which is very frightening, because it might not just be us, it could be our families, or, you know, as well. There's something about thinking about suicide that brings it very close to home. So that there are unconscious dynamics that could lead any of us to. And you just have to watch something like the Twin Towers. Now, this is very painful to talk about, but when you can actually see people making the choice, to die by their own movement and choice there rather than to remain and be subjected to something. So that there's something about suicide that is part of the human condition. And we all have these unconscious mental mechanisms that can lead us to do this. And we don't understand these mental mechanisms. We actually try really hard not to think about them. And there's only been a couple of psychoanalysts that have really tried to think about them. There's only been a few. And most recently, Don Campbell and Rob Hale and Don Campbell have written a book about working in the dark, the unconscious, really trying to understand the unconscious processes that lead someone to die in this way. So, suicide is very complex. It's not a simple thing, and it's very unlikely that someone has just made the decision in that moment to die, that there have been a very long run up, and that the etiology for suicide might even have started in the womb. There's a lot of suicidologists that think that 50% of the outcome of dying by suicide is genetically, it has a genetic propensity to it. So, there's a long run up to someone dying. There's many, many things that have happened in someone's life to mean that this happens at this point, and we don't understand it, and we'll never understand it, and we'll never know in any case why it's happened. And I think there's lots of evidence to back that up. I mean, actually, the more research that's being done into suicide, more observational research, I think the clearer it becomes. If you hear Nav Kapoor talking about this, that with what the National Confidential Inquiry finds out, that every year 73% of people who die by suicide haven't been in contact with mental health services at all in the last year. So that's only 27% that have. And of those 27% that have, 95% of those who've had a risk assessment at their last contact with mental health services are rated at a no or low risk. So it could be that we just haven't got the right tools, or it could be that actually it's very, very difficult to know or predict if this is going to happen, if someone is going to do this act in their future. And they themselves might not even know. So when people have survived very serious attempts, they often haven't known themselves they're going to do it, which makes sense because suicide would be something called an acting out event. And you act out, it's the defense mechanism, you act out when you can't put something into words. So when you can't symbolize something, so you can't symbolize emotionally, you act, and it's through the action that you realize that you feel something. So I might do something. We all act out all the time. You might say things, oh, good heavens, why did I say something? We might actually do something, go out and get drunk when we're stressed, or get into an argument, or get into a fight, or do something, have all sorts of different ways we act out. But it's often that action that allows us to know we feel something. So if this is right, then there are many people who make very serious suicidal acts and who don't survive. And that is the first that they know about them being suicidal. They're acting. And if they survive it, they can say, quite often they'll say, I didn't know that I was going to do that. I had no idea that that's what was going to happen. So quite often people don't know themselves that this is what's going to happen. So that's another aspect of that. And also going alongside with that is that people are very, very, people who survive, and not people who survive the event, but the people around them who are left are nearly always, if not always, totally shocked about this happening. And again, this is very difficult because all of this adds up to us not knowing it's going to happen, not knowing why it's going to happen, not knowing who it's going to happen to. And this is very difficult to deal with. So we create narratives. So very, very, very narrative is, okay, they were looking at social media. And of course, there might be a trigger in that, but that isn't going to be the whole reason that they've got to this point. There'll be many, many more factors that we don't understand about why they've got to this point. And even if even if social media is a trigger, which it might be, we're not going to know that because the person that's here isn't here anymore. So it's difficult. It is difficult to talk about this because it leaves us in a state of sort of unreconciled grief. It's very difficult, isn't it? And I think we have a lot of compassion, huge amount of compassion. It's something we fear, losing people we love to suicide, and have a huge amount of compassion for those that are bereaved in this way. So I think that's probably very important to say, really. So those are just some of the there's a lot more there, and
how can people get hold of you? What's the best way for people to read your books and your articles and get hold of your
Oh,
presentations?
well, I don't. So we've done some research on. We've done some research on the effect that suicide has. We've got myself and my colleague Joe O'Reilly have edited a book called Seminars and the Psychotherapies, which is a Royal College book published by Cambridge. And it, and that's and in that book, that's actually, I mean, I think it's a good book. We've contributed to it, but we've also got lots of many other contemporary medical psychotherapists who are working within frontline mental health services to write chapters about different mental health difficulties, about contemporary understanding of different areas of psychiatry and mental health. There's about organizational functioning. So there's many different chapters addressing lots of different areas within mental health, and thinking about the psychodynamic understanding of these different areas. And I mean, I think online has got open access to some of the articles and research we've done. So if you put my name probably into Google.
Yeah,
and the impossibility of working in the current NHS is the Tavistock Institute, one of the Tavistock Institute talks, which is available.
Yeah. I mean, we do need to sort of have another discussion about how we go forward with the NHS and the current situation. I think that'll take quite some time to unpack.
Yeah, I think so.
I'd like to finish on this. What would your 3 top tips be to yourself, who is about to embark on a medical career, about to start medical school, having gone through what you've gone through over the last 10 years, of course?
Live it. Just live it, live it. Follow your heart. Definitely follow your heart, but also know when it's time to leave. And I think that's a really important tip in general, is to really tune in when it's time to change and to leave something. And I think what I see happen in the NHS is when people don't leave, we all have a creative, the creative engagement in a relationship. And there's a time when it's creative, and there's a point when a relationship, be it with your workplace, whatever, might end. And it's a very difficult thing to work out, isn't it? When a relationship's ended, it's very painful. But there's something about being able to tune into that. And when I've seen people not work it out in the NHS, for example, but this is true in relationships as well, when they stay, when it's gone beyond the time to leave for them, and it's stopped being creative, something stops working and becomes destructive. And actually sometimes something in this unconscious of the organization will make them leave. They'll leave through a grievance, or they'll leave through a complaint, or something disturbing will happen, which means they'll have to leave. But if they can tune in to what feels right to them, when it's right to stay and when it's right to make a different choice, I think that's a very important point that I would say, really.
Wonderful, Rachel. It's been a great pleasure listening to you, and thanks for coming on.
Okay, lovely to meet you.